I'm John Kolbe, and I'm President of the International Society of Internal Medicine. I'm sorry I can't be with you in person, but I hope that you have a very successful meeting. Today, I'm going to talk on the management of chronic obstructive pulmonary disease. You may wonder why I've chosen this topic in view of the fact that the GOLD guidelines launched in 2023 are a very comprehensive and very excellent document. However, as illustrated on this slide, some of the information contained within this document is not user-friendly, and in other areas, it's difficult to see how one might put the advice in the GOLD guidelines into a usual day-to-day clinical practice. And so in this talk, I'm just going to highlight a few points, and the first of these relates to the change in lung function which occurs over time. On the y-axis here is lung function, and you can imagine that that's FEV1. Under normal circumstances, there is an increase in lung function that occurs during childhood and adolescence to reach a peak in early adulthood. There is then a plateau of lung function between the ages of 18 and 25, and thereafter there is a slow but steady decline. In some people, usually related to exposure to cigarette or biomass smoke, there is an accelerated decline in lung function. There's tremendous variability in this rate of decline, but in some patients, the rate of decline is such that the patient has severe impairment of lung function later in life, leading to disability and death. And that's the classic model of the development of COPD related, for example, to cigarette smoking. However, it's now recognised that in a group of people, they do not achieve maximal lung function in early adulthood. And this is a result of insults occurring in early life. Then, as a result either of normal decline in lung function or an accelerated decline in lung function, these persons may experience such severe decline in lung function that they too experience disability and premature death. This importance of early events is highlighted in this table from the GOLD guidelines. It highlights that early life events, including prematurity, as well as childhood infections, both can impair the development of the lung, and thus there is a failure to achieve maximal lung function in early adulthood. In addition, on this slide, you can see the importance of childhood asthma, particularly severe and poorly controlled childhood asthma. This too affects lung maturation and may lead to the development of fixed airflow obstruction. Of note on this table is that for the first time, vaping and e-cigarette use is listed as one of the causative factors in COPD. If we look at the aims of management in COPD, as indicated in this slide, we would like to reduce symptoms. We'd like to improve exercise tolerance and improve health status. We'd also like to reduce exacerbations, to reduce the progressive decline in lung function, and to reduce mortality. Now, there is no treatment that achieves all of these management aims. And in fact, for a number of these management aims, we have very limited ability to produce positive results. First of all, smoking cessation is the only intervention shown to slow the rate of decline in lung function. Influenza vaccination is cost-effective and of proven benefit. Pneumococcal vaccination is probably also of benefit, but the evidence supporting this is nowhere near as good. Long-term oxygen therapy is the only treatment shown to reduce mortality. And remember, it's only in those with severe hypoxemia. Those with moderate hypoxemia do not derive a survival benefit from oxygen therapy. I do need to say that a recent large study has shown that triple therapy, which I'll explain later in this talk, has been shown to reduce mortality. I think that this was a surprise to everyone, and the effect of pharmacologic therapy on mortality, I think still there is a question mark about that. And finally, pulmonary rehabilitation produces the largest improvements in exercise capacity and health-related quality of life. So those points are summarised on this slide here, which shows that in cost-effectiveness terms, maximum benefit is obtained from flu vaccination, followed by smoking cessation, followed by pulmonary rehabilitation. And it's only then that drug therapy has an impact on outcomes in COPD. So that's the first important point, that those interventions which have the maximum effect are in fact non-pharmacologic. Turning now to pharmacologic therapy, the initial pharmacologic therapy is that of bronchodilators. And in this slide and the next slide, I summarise a great deal of data based on Cochrane reviews and a large number of other papers. The first thing to say is that long-acting antimuscarinic agents are better than short-acting muscarinic agents. All long-acting beta agonists are approximately equal, and all long-acting antimuscarinics are approximately equal. There's no proven benefit of one against another within these classes. In terms of outcomes, the long-acting antimuscarinic agents produce approximately the same effect of the long-acting beta agonist, at least in terms of health-related quality of life. There's possibly some advantage of long-acting antimuscarinics in terms of preventing exacerbations. But what you can say is that the combination of a long-acting antimuscarinic and a long-acting beta agonist is more effective than one of these drugs used alone. And the combination of these two is better than long-acting beta agonist and inhaled corticosteroids, the usual treatment that we would use in asthma. And in fact, the evidence would suggest that there is very little evidence to support the use of a long-acting beta agonist plus inhaled corticosteroids in COPD. And there is some evidence, which I will talk about in a moment, that the triple combination of an antimuscarinic agent, a long-acting beta agonist, and inhaled corticosteroids may be better than any other two agents. So in the clinic, what do? I trial one, usually a long-acting antimuscarinic, but you may wish to trial a long-acting beta agonist. You then assess the response in meaningful terms. I use FEV1 to make the diagnosis, but I do not use lung function to assess the response to therapy. I do that in terms of some activity that the patient undertakes on a daily basis that causes them to be short of breath, and to determine the response of that to the addition of the medication. And then I'll add the other and assess the response. For some patients, there may be an advantage of once versus twice daily use of therapy, but I know no good evidence to indicate that once daily use increases adherence to medications when compared with twice daily use. And then there's the importance of the preparation and the delivery service. Is there a need for a spacer? How easy is it for the patient to use the device? Do you want to administer all medications using the same device, or perhaps even combined within a single device? Just a few other things to say about drug therapy in COPD. As opposed to asthma, there is no risk of unopposed long-acting beta agonists in COPD. In other words, it is not necessary to combine the long-acting beta agonist with inhaled corticosteroids in COPD. There is also good evidence that COPD is not a contraindication to the use of beta blockers for the patient's perhaps coexisting cardiac disease. There is also evidence that there's no good indication for the very widespread use of inhaled corticosteroids. In Western countries, inhaled corticosteroids are used in up to 80% of patients with COPD. And remember that inhaled corticosteroids in this population is not without its downside. There is an increased risk of pneumonia. And remember that pneumonia is not a trivial condition in this patient population. Following pneumonia, mortality remains increased for at least a year, probably double for at least a year. And this is due to cardiovascular causes, probably related to the ongoing systemic inflammatory response. And if someone is on inhaled corticosteroids, there is reasonable evidence to suggest that these can be safely withdrawn if you think that there is no clinical indication for inhaled corticosteroids. Having said all that, there may well be a subgroup of COPD patients that benefit from inhaled corticosteroids. So let's turn to the GOLD recommendations and see what they say about the use of inhaled corticosteroids. They suggest that they are indicated for patients with at least one exacerbation per year and a peripheral blood eosinophil count of greater than 300. So where does that information come from? Well, or where is the support for that recommendation? Well, there was a great deal of retrospective data suggesting that those with higher peripheral blood eosinophil counts are more likely to benefit from inhaled corticosteroids. But this is one of the first studies that looked at that in a prospective way. And this study, reported in 2018, compared triple therapy, that's a long-acting beta agonist plus inhaled corticosteroids plus a long-acting muscarinic, against a long-acting beta agonist plus inhaled corticosteroids against a long-acting beta agonist and a long-acting antimuscarinic. And as you can see in the box on the left-hand side of this slide, in terms of exacerbation rates, the triple therapy seemed to have an advantage over other combinations. Now, that's not the purpose of showing this slide and or discussing this particular study. And there are issues related to the study, but that was the bottom line result. If, however, we look at the exacerbation rate against peripheral blood eosinophil counts, you can see that those on inhaled corticosteroids, the purple band and the red band, the rate of exacerbation showed no change with increasing peripheral blood eosinophil count. However, those on inhaled corticosteroids, the green shading, there was an increased rate of exacerbations with increasing peripheral blood eosinophil count, and the cutoff seemed to occur around about 200 at the level of around 200 eosinophil count. So the important thing about peripheral blood eosinophil count and an outcome in COPD is that the relationship is a continuum, and it's not adequately described by dichotomizing peripheral blood eosinophil count with a cutoff of 200 or 300 or whatever. And it seems biologically implausible that there's a magic number that predicts the response to inhaled corticosteroids. Furthermore, as you're well aware, there's an inherent variability of peripheral blood eosinophil count. So perhaps we shouldn't focus on a dichotomy and accept that cut points are a guide at best, and that in terms of individualizing patient management, we should consider other factors that may influence our clinical decision. So this is what I propose. We look at the peripheral blood eosinophil count. If it's low, then say less than 200, then the patient is unlikely to respond to inhaled corticosteroids, and they should be treated with a long-acting beta agonist and a long-acting antimuscarinic. If the count is greater than 200, and remember, the higher the count, the more likely they are to respond to inhaled corticosteroids, then we consider other factors. First of all, other factors that might indicate benefit, for example, the rate of previous exacerbations, or perhaps a history of asthma. And then we consider factors that where inhaled corticosteroids might cause harm. Is this patient at increased risk of pneumonia? Are they at increased risk or are they at risk of non-tuberculous mycobacterial infections? And what about other adverse effects? Bone mineral density, skin thinning and bruisability, which occur at standard doses of inhaled corticosteroids in this usually elderly population. So this schema takes into account these other factors before making the clinical decision as to whether or not to start someone on inhaled corticosteroids. So the messages. First of all, that the etiology is wider than exposure to cigarette or biomass smoke, and the fact that events which occur in the neonatal period or during childhood may have a major effect on the development or otherwise of COPD. That non-pharmacologic management or forms of non-pharmacologic management have the greatest impact, particularly in terms of health-related quality of life. That bronchodilator therapy has priority, preferably the combination of a long-acting antimuscarinic agent and a long-acting beta agonist, and that whilst there is not an indication for the widespread use of inhaled corticosteroids, these agents are likely to be useful in a proportion of patients with COPD, and I provided you with a schema as to how you might approach that decision making. So thank you very much for your attention, and I wish you all the best for your meeting. Thank you very much.